no significant mortality difference and no significant renal outcome difference. However, as is the case in many of our critical care trials, we've done such a good job that the control group often doesn't get that old standard of care. So they found that in this study, that the majority of the patients actually had medications that were circulating in normal saline. So it was really hard to tell who was truly on just normal saline and who was truly on just P-Lite because of that cross-contamination effect. And so people wondered, did that actually kind of attenuate the benefit of P-Lite? Would you have seen a better P-Lite stats if you had taken out that medication effect? Remember, too, that fluids are just one component, one tool in our toolbox of resuscitation. And what I tell the trainees all the time is that in tandem, you're thinking about fluids, you're thinking about pressors, you're thinking about adjunctive therapies like steroids, but the whole time we're thinking about source control. What is our underlying cause? Why is this still brewing and going on? And how can I stop this vicious cytokine cycle of this patient? So again, you're thinking about the pressors, you're thinking about the fluids, but you're also thinking about, why am I in this situation still? What's going on with the patient's physiology? Could there be multiple processes? Could I be missing something? And don't forget to diurese on that tail end. DC IV fluids before you're DCing home. So most of our patients are actually going to need that rescue period where you're fluidizing them, you're bolusing them up front, you're optimizing, and then you want to start gently diuresing them. Even if their pressure requirement is still there, but maybe it's downtrending, then it's safe to diurese. So sounds scary at first, definitely, but it's really important to get that extra fluid off because, again, that extra fluid causes harm, particularly for the lungs. So rescue them, optimize them, stabilize them, and then de-escalate your fluids. And then speaking of de-escalation, our last confusing fluid trial, which was from New England Journal last week. So this was Myhoff et al., they with great hubris, named their trial the classic trial. Whoa, okay, we'll see. Critical care trials tend to come and go. But the classic trial really showed when they looked at standard fluids, which they thought as, you do what you want, basically physician discretion, about 30 cc's per kg IV fluid, versus a restrictive fluid strategy. And what they mean by restrictive fluid strategy is just what I was advising. They were saying, don't give fluids indiscriminately, just give small boluses in response to what you think the patient needs. So if your lactate is rising, if your urine output is dropping, if your blood pressure is dropping, then you want to give small 250 to 500 cc's boluses as you need. So that's what they meant by restrictive. And they actually found no difference in restrictive versus liberal fluid strategy. Once again, though, there wasn't a huge difference in what the physicians did in both of these groups. So that makes it hard to interpret. Just like a lot of these transfusion trials, right? The control group has already gotten with the program that dry lungs are happy lungs. And so maybe, once again, that benefit was attenuated. Maybe restrictive fluids would have had even more of a benefit if there was a larger spread between these two groups. But key point here, again, it is safe to go for that restrictive fluid strategy. There wasn't a mortality benefit, but it was safe. You may be thinking here, oh my goodness,